Mandy.
Yeah.
Say hi. Say hi, Dr. Jones.
Hi, Dr. Jones. I'm just texting.
Okay. So today we are going over the post-rehab guidelines of the shoulder. Okay. So last time we kind of briefly touched on anatomy, kind of introduced you to the muscle structure so that we could lead into today. Okay. So we went over last time, we did a brief kind of rough drawing of the glenohumeral joint. We did a rough summary of the different types of joints that you have in your shoulder, and then we kind of went over the muscles and what they do, yes? Okay. So today we're going to go a little bit more in depth, okay? So if you look at this first sheet that you have, okay, this is the bony structures and bony landmarks of the shoulder, okay? So look at the top drawing up here. If you look, okay, and you have notes on pretty much all this stuff, so you're not going to need to write a ton, except if you're going to write on those sheets, okay? So when we talk about the glenohumeral joint, it is between, so here's the glenoid fossa, okay, or glenoid cavity. So this is the right shoulder blade, okay? So the spine would be over here, humerus would be right here, okay? Does that make sense? Are you guys close enough to see all this?
Yes, I'm trying to find where that is.
It's on page 3. Okay? So top drawing, over on the right side, so the glenoid cavity. And then over beside that would be where the humerus sits. So if you look at this one down here, okay, this is the humerus, this is going to be your glenoid fossa. A fossa just basically means like a depression or a cavity. So, when we were talking about stability last time, what did we say about the hip joint? Why was it so stable? What makes it so stable? So think about what we've talked about with hips, knees, all that kind of stuff.
The hip joint is stable?
The hip joint is super stable because why? What kind of joint is it?
Ballpark.
Okay, which means ball and socket. So it means that there's your head of your femur, you got this big ball of the femur coming in, and the congruency between the two bones is super tight. And then you got a labrum on the inside, which is cartilage, which creates kind of like a cut around that joint, which makes it super, super stable. And then the ligaments are super strong in there, and then you got your big daddy, glutes, hamstrings, psoas, TFL, all that kind of stuff on top of it. So there's a lot of stability and a lot of strength going through it. Now when we look at the shoulder, we don't have that, okay? The shoulder is a very shallow joint, so it sits like this. It's like a C, okay, a big C, a wide open C. So the hip joint was more of like a curved over C. This one's like a big C, okay? And then you got your head of the humerus coming and sitting right here. There's not a lot of congruency here. It kind of floats, okay? So what is going to help with the stability of the glenohumeral joint, which is your main shoulder joint? So you got the glenoid fossa, you've got your humerus here, and then if you see this highlighted spot right here on this sheet, okay? So on page 1, where that's kind of shaded in there, that kind of black mark, you actually have a labrum in there as well. So you have a glenohumeral labrum in there. So what the labrum is a cartilaginous disc that is going to somewhat cover the head of the humerus and sit inside that glenoid fossa, which is going to increase the depth of the joint. So it's going to make the congruency a little bit better. Does that make sense? So this is a shallow ball and socket joint. Okay? So remember that. When I ask you the difference on a test between what's the difference between a hip joint and a shoulder joint, in regards to bones, ligaments, and muscles, then you'll know. Okay? So, when we talk about this joint, I'm going to try and draw this happy time. Okay? So, if this is the glenoid fossa, we're looking at page 1, but it's hard to see on there because I have to draw it. But if you look at page 1, okay, this is what your scapula kind of looks like. You got this, you got your acromion process, the coracoid, then here's your clavicle, okay? So that's that fossa, and then it's going to kind of come down like this and come up, okay? So right here is going to be your labrum in this area, this little Z This is going to be the head of your humerus that comes down like this, kind of sits in like that. Okay? So when we talk about, we talked about the bony structures, and we'll go over the joints here in a sec. But when we talk about that glenoid fossa, what's really creating a lot of stability up there are going to be your ligaments in your joint structures. So when we talk about this, I'm going to kind of go back and forth between the bony articulations and the ligaments. So there's a Z that sits like this. So it goes here, and it goes here, okay? So those are called your glenohumeral ligaments, okay? So these are your glenohumeral ligaments. Remember, glenohumeral is like Zorro, okay? So this supports this shoulder joint anteriorly. Does that make sense? So how these are labeled, all right, is pretty easy. So going through those anatomy terms we go through, this is going to be your superior glenohumeral ligament, the top one. Then you got middle. Okay? These Latin guys got lazy on this one. And then you got your inferior. Okay? So you got superior glenohumeral ligament. Then you got your middle glenohumeral ligament.
Middle?
Glenohumeral ligament, yep. And then you got your inferior. Okay? So that kind of makes up that joint structure. So you got the bones, so this is talking about the glenohumeral joint. So you got the bony articulations, which I just talked about, the structure of it, and then you got those ligaments in there. Okay? All right. So let's go move on. So now we're going to go into some of the other joint structures. Okay? So I'm going to take these out. Everybody got that? I'm going to leave a Z in there, but we'll take that out. So you're there. And you got this little crazy coracoid process. Just says that. Get your fossa. Okay. It's better than last week, isn't it? All right. There.
That's like an ear.
You're an ear. Okay. So this is the underside of the scapula, obviously, okay? I'm going to make this a little bit better. It's like a little bit crazy. Okay. So, what was this joint right here? So, what was this joint right here? Sternoclavicular, good job. Sternoclavicular. Okay? What was this joint right here? So it's a joint between the clavicle and then this weird process name we were talking about. AC joint, acromioclavicular, okay? So acromioclavicular, AC joint. Okay. What? Okay. I know. I'm just testing it here. Okay. So yeah, all the answers are pretty much on those sheets. Okay, so sternoclavicular, acromioclavicular. Now, what was the, then we have the glenohumeral, so I'm just going to abbreviate it. So glenohumeral goes right here. What was the joint, if we flip this on the other side, what was this joint that was over here? So if these are the ribs, what was that on the back side? So, that's sternoclavicular,
oh.
right here. So this is the scapula.
Scapulothoracic.
Scapulothoracic, perfect. Scapulothoracic. Okay, so pay attention to those, okay? So we're going to really go over those a lot. Okay, so those are the joints. Those are the big daddy joints that we have going on, okay? Now, in between all these joint structures, there's ligaments, okay? And the ligaments provide a lot of stability as well. Okay, so you don't necessarily, I'm not necessarily going to test you on this stuff, on these little tiny ligaments, but they're good to know. Are they really going to come up? I'll probably tell you. if they're going to come up, like if somebody jacked up their coracohumeral ligament or something like that, I'll go over it with you, talk about it, all that kind of stuff. So for what you guys need to know right now, it's not, you need to know it, but you don't need to like memorize it right now. Okay. So the other, what I'm trying to do is I want to give you an idea about what the anatomy of the shoulder looks like. So when we talk about some of the conditions later, how I figure out what's going on with someone's shoulder is if you know the anatomy and you know what's supposed to happen functionally, then when that doesn't happen, you go back and say, well, what's going on with the anatomy that's causing the dysfunction? Does that make sense? So yesterday when we were working with Casey, you took her through an exercise protocol with Steph, and we're putting them through the same workout, but with her, it was like, well, she has a minor rotator cuff tear, so what are we watching out for? Does that make sense? So if you see something like, well, why does the shoulder keep doing this? Why does it keep doing this? Why does it keep doing this? Or why does it keep sneaking up? Then we'll figure that out. If you know the anatomy and what it's supposed to do, then when it doesn't do that, you find the problem and you work your way backwards. Okay? Okay, so.
What's the difference between the fact that I have a lot of people that do that?
Well, and I'll get into that. I mean, you have people that have the predisposition to that, so they have faulty movement patterns, but they have not manifested in a rotator cuff tear yet or frozen shoulder yet. However, they may have a bursitis, they may have a tendonitis, or they may have just muscle-like imbalances that are causing a little bit of impingement. That's why their shoulders hurt and ache.
Yeah.
Does that make sense? Yeah. Now, just so we're clear, because I couldn't draw this very well last week because I have these drawings to go off of. I draw really well when I actually have something to go off of. This is your coracoid process. So this is the one that you feel, like when I'm pushing on you here, and you're like, ah, and you feel that when I drive in on that pec minor. That's what your pec minor attaches to in the front. So it starts up here and it comes down. Your coracoid process, there's also some of it that the biceps attach to and everything else.
Process always in something that's
A process is something that sticks out. Okay? A fossa, the hole, a tubercle is a bump. A foramen is a hole or like a tube, like your vertebral foramen, your spinal cord runs through. Like your obturator foramen, your sciatic nerve runs through, and your hip, which we'll do next. Okay? So let's go over some ligament structures, okay? So coracohumeral. Where do you think that is?
up there.
Coracoid, humerus. Boom. Okay? You don't necessarily have to write these down, but just pay attention to where the anatomy is. Okay, what about your coracoacromial?
It's going to go from where that arrow is at the top to down.
Right. Okay. Now this one is important. Okay, so that's your coracoacromial ligament. Okay, so draw that in on that sheet on number 3. So find your acromion process. You can either do it on either one of these. I did it on this one. So you got your acromion process and your coracoid process. Draw a ligament in between there. Does that make sense? So there's your acromion and there's your coracoid. Yeah, right there. Okay. Do you have different colored pens or not?
No.
Okay.
I have a pen over there.
Go get it, because it's important. Jog.
Ow.
Ow.
Jog, ow.
Yeah.
Real quick, if someone came into you with frozen shoulder, like not Julia, what do you do?
There's a protocol for frozen shoulder. You know, a lot of it is that, and we'll get into this, why this happens, but that this space that you see in here, it's called your subacromial space, gets really small because there's a lot of inflammation that happens in there, and it just inflames. Is that filming or no? Where's it filming?
Filming you from here down.
Damn it.
Oh my god. Yeah.
There's no way it moves.
It literally, yeah.
That sucks.
Yeah.
It moves.
Hold on, Dr. Jones.